The topic is machine perfusion, new dawn or optimistic hyperbole. The idea of perfusing isolated organs is not new. There was lots of interest in this long before the era of clinical transplantation. This image on the left comes from the Journal of Experimental Medicine in 1935, describing a series of experiments carried out by Lindbergh and Carell, very famous in their own right, both as aviator and researcher. And they found themselves on the front cover of Time magazine 4 years later, which doesn't happen to many surgeons, or for that matter, scientists. And in fact, it was not for another 30 years that another transplant surgeon found their face on the front cover of Time magazine. But what's this all about? Why are we replacing good old-fashioned technology, i.e. an icebox, with something which is so complicated, so expensive? What is it that these two young surgeons are staring at with such interest in this box? The answer is it's a liver which is functioning. It's fully perfused, it's fully functioning, it's running at 37 degrees centigrade, it's having oxygen, it's having nutrition, it's been given all sorts of additives to make it function completely normally, and the objective, of course, is to allow it to be preserved without injury, and indeed to recover, to repair itself, and potentially to be available for therapeutic interventions. Well, if we look at liver transplantation, on the face of it, it is simply a success story. Look at what's happened in the UK over the last 10 years. The number of organ donors has increased, which is good. The number of transplants has increased. We topped over 1,000 liver transplants last year. And the waiting list has come down. It's 359 at the beginning of the financial year. But actually, it's not as successful, not as straightforward as that. The demand is going up actually significantly faster than the supply, and that's because liver failure is increasing and cancer involving the liver is increasing. Meanwhile, the suitability of the organ donors rather than their number is decreasing. Organ donors are on average now older and have more medical problems, diabetes, cardiovascular disease, etc. There are more donors who are being declared dead by cardiovascular criteria, i.e. cardiac arrest, rather than brain death, and that brings with it an inevitable injury, a hypoxic injury. And as a result, these organ donors are actually not as well used, not as well utilised as we would like. And in fact, in the UK, slightly less than 2/3 of deceased organ donors result in a liver transplant. And this is associated with a substantial waiting list mortality. There are about 60 patients died on the transplant waiting list last year. And even then, we are very restrictive as to which patients get onto the waiting list. So last year, there were almost 1,600 organ donors, 1,149 livers retrieved, 85% of those were transplanted. And if we look at the split between the brain dead, that's what we call DBD, and the circulatory arrest, that's DCD, that's where the figure of 62% comes from. And it's the high-risk livers which are very, very poorly used. So that's really what we're going after. It's these poorly utilised donor organs. So what's that got to do with organ preservation? Well, really four things. The icebox has got problems insofar as, first of all, cooling down biological tissue is not very good for it, and the damage is not entirely reversible. The second, there is no oxygen delivery in the icebox, and we now know that even at ice temperature, delivering oxygen is important in terms of the switch to aerobic metabolism. As a result, anaerobic metabolism leads to the accumulation of metabolites, and these metabolites form the substrates for what we call ischemia reperfusion. And finally, because the organ is not functioning normally in the icebox, we can't measure its function and work out whether it's a viable liver or not. That's absolutely fine if the liver is a perfect liver from an ideal donor, a 25-year-old head injury, for example. It's not fine with high-risk donor organs. These limitations become more severe. So there's lots of interest in machine perfusion, trying to do something better than the icebox. And these 4 devices shown here are all different devices designed and in clinical trials or on sale for the perfusion of human livers. And there are really 3 issues, one of which is whether perfusion makes a difference. The second is whether it's important to deliver oxygen. And the third is which temperature to do it at. There has been quite good evidence for a long time now that cold perfusion, simply pumping a solution through an organ during preservation, is better than static cold storage. And this device shown here is a kidney perfusion device. It's been around for quite a long time, and variants along this line have been around for several decades. And there is evidence that it's beneficial in higher risk donor organs. But developing this in the context of the liver is a much more recent phenomenon. This was the first paper to describe just that, which is a very simple machine perfusion system of a human liver, and it was shown to be feasible and safe. And we're really waiting more substantial evidence as to whether it adds value rather than just being possible. But we do know, and this is a much more recent phenomenon, that delivering oxygen, even when organs are in the refrigerator, even at ice temperature, is important. And it's all about mitochondrial metabolism. Accumulation of succinate in the mitochondria is a universal feature of ischemia, and it accumulates. And at the time of reperfusion, in other words, the time that oxygen is reprovided, there is reversal of an enzyme at mitochondrial complex 2, which results in the generation of reactive oxygen species at complex 1. And reactive oxygen species are the essence of what happens when organs are retransplanted and experience this so-called ischemia reperfusion. And the reason why the oxygen thing is important is that giving oxygen prevents succinate accumulation, and that works independently of temperature. And that's the recent finding, which probably matters a lot. And this concept has been translated into a hypothermic oxygenated perfusion, here in the context of the liver, whereby livers which have been retrieved with oxygen depletion, so circulatory death livers, stored on ice for a few hours, and then given a brief period of machine perfusion with oxygen. And the preliminary results of these studies look very encouraging. Randomized clinical trial data not yet available. But what we're discussing today is normothermic machine perfusion. That's recreating the physiological environment. That's pumping the organ with blood at 37 degrees centigrade with oxygen, with nutrients. And this allows normal metabolic activity. It allows prolonged preservation. It allows viability assessment, because you can measure the function of the organ, and it should allow organ repair. So that's the hypothesis that we are discussing this morning. I'm now going to hand over to my colleague David Nasralla, who spent 3 of the best years of his life working on this.
They were 3 great years, yeah. Bernard, thank you very much, Prof. So, as Professor Friend said, I'm going to talk about the clinical application to date of normothermic liver perfusion. So, the first clinical studies in man were done, again, here by our group in Oxford. They were published a couple of years ago in the American Journal of Transplantation. And their 20 human livers that were preserved using normothermic liver perfusion were transplanted at King's College Hospital, London, and the Queen Elizabeth Hospital, Birmingham. And that study essentially showed that normothermic liver perfusion was feasible and it was safe. And on the basis of those findings, we then moved on to perform a much larger randomized control trial. So this was one of several clinical trials being run by the COPE Consortium, so the Consortium for Organ Preservation in Europe. It was funded by the European Commission and sponsored by the University of Oxford. It took place in 7 European liver transplant centres, so 4 in England, 1 in Belgium, 1 in Germany, and 1 in Barcelona in Spain. And we needed to randomize 220 livers into the trial, and they were randomized in a 1-to-1 ratio to either conventional static cold storage or normothermic perfusion on the machine. Now, in an ideal world, the primary outcome for such a study would be 1 year graft survival. But the problem is graft survival in the UK is very high, and to power such a trial, you'd need very large numbers. So we chose a surrogate, and that surrogate we chose was the peak transaminase levels. And we know from a large number of studies that the peak transaminase levels in the first week after transplantation correlate well with the likelihood a patient will die, the likelihood the graft will be lost but the patient will survive, or the likelihood that the graft and the patient will survive. And so this study had a 90% power to detect what we felt would be a clinically relevant 33% drop in the peak AST. We also looked at a large number of secondary outcomes, including organ utilization, which is perhaps the most important question facing the transplant community due to the shortage of organs, and also preservation time, the incidence of post-reperfusion syndrome, so that's a measure of the degree of hemodynamic instability that a recipient suffers after the transplant, and that limits the organs that many recipients can be eligible for. Early allograft dysfunction, which is another measure of early graft function that correlates with later graft survival. Biliary injury, which in DCD organs is really what limits their usage because many of those organs suffer biliary injury and biliary strictures. And then the other aspects listed here. The way the trial worked was that once an eligible liver was matched to a recipient who was consented for the trial, then the liver was randomized. If it was randomized to cold storage, then the organ retrieval, preservation and transplant process all happened according to conventional standard practice. If it was randomized to machine perfusion, then a researcher and the device traveled out to the donor hospital, and once the liver was out, it was placed on the machine where it remained until it was transplanted. And all of post-operative care was continued as per normal practice. So the way normothermic perfusion works, the mechanics of it are shown here. You essentially have a liver in a bowl, and that liver is cannulated. So there's a cannula in the portal vein, hepatic artery, and vena cava. There's a blood-based perfusate which flows out of the vena cava to this pump, which pumps it up to a heat exchanger and oxygenator, and this warms the perfusate to 37 degrees and oxygenates it. And then from there, it's either pumped directly into the hepatic vein, and that's a high-pressure, low-flow system. High-pressure, low-flow, or it's pumped up to the reservoir from where it drains under gravity into the portal vein. And so that's a low-pressure, high-flow system, sort of mimicking your normal physiology. It's taken a few years to develop that circuit, or to develop the final looking circuit. This was about 20 years ago, although it looks like it's from the 1920s. But here it's actually essentially the same circuit, but you've got the liver in a bowl, you've got an oxygen tank and various other tubes and so on. And that appearance has been gradually refined until we've ended up with the device we used in the trial. But it has exactly the same circuit I described. The perfusate comes out of the vena cava to this pump, travels up to the heat exchanger and oxygenator, and then either goes straight into the hepatic artery or up to a reservoir from where it drains under gravity. We've got continuous infusions of heparin, insulin, prostacyclin, and bile salts, and this display gives continuous real-time information about the metabolic, synthetic, and flow dynamic characteristics of the liver. Once we had travelled out to the donor hospital with the machine, and once the liver was out of the donor, once we got to the hospital, we had to set up the device. It comes as a naked chassis and a disposable set, which is then mounted on the chassis and primed with blood to end up with this appearance. And then once the liver was out of the donor, we have to prepare it. So this is where there's a change in normal practice. So once the liver is out, we have our own kit we take with us. We first have to close off, so this is the vena cava with the caudate lobe of the liver there. So we close off the top end of the vena cava with a stapler and then cannulate the bottom end, as shown here. We then cannulate the portal vein, the hepatic artery, the bile duct, and then transfer that liver into the bowl on the machine and connect it up. And this shows that process. So in the bowl here, we've got a Y piece, which we remove initially. And we've then got these end pieces onto which we can connect the cannulas that are already in the liver. So this yellow one connects to the portal vein, red one to the hepatic artery, blue one here will connect to the IVC. And we should have a liver that we prepared earlier coming into screen now. So this is a healthy looking liver. rather than some of the larger steatotic ones we sometimes end up with. Again, here you can see behind my hand the vena cava traveling through the caudate lobe, which has been cannulated. And we first take some time to arrange the cannulas and then get rid of any air that's left just at the end of the tubing and connect those cannulas up. With the portal vein, there have been cases where there have been twists in the portal vein that have been missed. So we take some time to make sure that is correctly positioned. And then finally, we connect the hepatic artery. So we're just untwisting the portal vein here. So finally connecting up the hepatic artery, and again removing any gas that's left in the end of the tubing. And then once that's all done, we open these clamps. And that final tube we're just manipulating is the a silicone tube sitting in the bile duct. And then once that's done, we start the perfusion. And the first thing you'll see is flow going into the hepatic artery, and then coming out of the vena cava, and then finally going in through the portal vein. And if it's a nice liver, it will perfuse fairly homogeneously and it will pink up relatively quickly, as this one is doing. If it's not as nice a liver, it may be far more patchy, the perfusion, and it may take a good while for it to have a nice appearance. But the other good thing about this setup is if there is any vessels you've missed, such as here, there'll be some bleeding in a moment from an adrenal vein that's been missed, that can then be addressed and tied off. So it's possible to do further backbench work and preparation of the liver during machine perfusion, as well as potentially do other therapeutic interventions. Fine. So the way in which the trial panned out in the end was we needed to randomize many more livers than expected. So we ended up randomizing over 300 livers, of which 62 were withdrawn. This was mainly because the DCD donors, those who die after circulatory death, they didn't actually die in the required time period, so couldn't be included. And that's not uncommon. So we ended up with 270 livers that were included in the trial, approximately 50-50 split between the two arms. But then there was a notable disparity between the number of organs that went on to be discarded after inclusion in the trial, so after they'd been retrieved. So 32 were discarded in the cold stored arm, 16 were discarded in the machine perfused arm. So we ended up with a difference in the number of livers that ultimately went on to be transplanted. In terms of the results, our donors and our recipients were well matched in all characteristics. The primary outcome from the trial, as I said, was the peak transaminase levels, so this was sort of the headline outcome, and we'd powered the trial for a 33% reduction, and in the end we saw a more than 50% reduction in the peak transaminase, and that was statistically significant. When this was broken down by donor type, for brain-dead donors, so those are better quality organs, the reduction in peak AST was about 40%. For DCD organs, which by their nature are extended criteria or much more marginal types of livers, that reduction was over 70%. So we saw a much greater improvement in that group of donor organs. Moving on to organ utilization, so this was the number of livers that were retrieved that ultimately went on to be transplanted. As I said, there was a notable difference in the number of livers that were discarded in both arms, with 24% discarded in the cold arm and 11% in the normothermic arm. So there was better organ utilization in the normothermic group. And this was probably a reflection of the number of steatotic livers that were utilized in each group. So fatty livers have a much higher rate of of non-function after transplantation, so surgeons tend to be much more hesitant to use them. But we noticed that in the normothermic arm, about a quarter of the livers that went on to be transplanted were moderately or severely steatotic, compared to just over 10% in the cold stored group. And when you look at the characteristics of the discarded livers, it was notable that many more of those that were discarded in the cold arm were steatotic. One of the other problems in transplantation is that the longer an organ is preserved for, the poorer the outcomes after transplantation. So over here, we've got all the livers in the trial ranked according to their preservation time. Every red bar represents a normothermic liver, every blue bar represents a cold stored liver, and they're ranked according to their duration of preservation. And you can see that in the normothermic group, the duration of preservation was much longer, and that was shown in the findings from the trial. And we know that many centres started to organise their theatre logistics according to whether the liver was on the machine. So even if we had two livers arriving at the same time, they simply queued them up rather than trying to open additional theatres and sort of cancelling other cases. Some other centres also rescheduled transplants, so rather than doing them in the middle of the night, they moved the operating time to daylight hours, which again we know has logistical benefits for the way theatre departments are run. As you may remember, Post-reperfusion Syndrome measures the degree of hemodynamic instability in recipients after their transplantation. And again, here we saw 33% rate in the cold stored group compared to 12% in the normothermic group. So there was a measurable improvement in the hemodynamic characteristics of recipients after transplantation, which correlates with graft injury and also is likely to increase the number of organs that can be considered for some of the sickest recipients. Another measure of early graft function is early allograft dysfunction, which correlates with later survival. Here we saw rates of 30% in the cold store group, which is similar to those quoted elsewhere, with much lower rates in our normothermic livers. In DCD organs, as I mentioned, the big factor that has limited more widespread utilization of such organs is the risk of bile duct complications, with as many as 1 in 3 patients getting biliary strictures. As part of this study, all patients underwent an MRCP scan at 6 months after transplantation, regardless of whether they had symptoms. And this was actually something that had never been done before in any previous study. So the radiological rate of biliary strictures in otherwise asymptomatic individuals has not previously been described. And what we found was that in about 10% of the normothermic DCD livers, there was evidence of biliary stricturing, compared to about 26% in the cold stored group. However, this did not translate into any into clinical findings, with only 1 patient in each arm of the trial actually suffering significant clinical consequences as a result of these biliary strictures. So actually the clinical relevance of these MRCP findings is not clear. And then finally, graft and patient survival. We've gone out to 2 years now. There's no measurable difference in graft survival at 2 years. Perhaps the greatest benefit from machine perfusion will be the ability to assess organ viability and to help guide organ utilization. And as I said, during machine perfusion, you can measure metabolic, synthetic, or hepatocellular characteristics, as well as perfusion flow dynamics. With regards to biliary stricturing, there's many groups that have tried to look into this during machine perfusion to determine if there's anything that can be measured while the liver is on the machine that may predict the likelihood of strictures. It doesn't look like bile production shows any relationship, but the group from Cambridge have shown that bile pH does appear to potentially predict the likelihood of developing later strictures, with patients that had more acidic bile later going on to develop ischemic cholangiopathy. Other groups feel that lactate clearance may be a better marker of viability. We saw that in pretty much all the livers that went on to be successfully transplanted, lactate was cleared very quickly from the circuit. Although, again, the group in Cambridge feel that it may not be as good a predictor, with they've had 1 liver that didn't function after transplantation that did manage to clear lactate. But I'm going to give a few case examples now that will show how the assessment of organ viability has been used to guide organ utilization in real clinical practice. So here we had a severely fatty liver from a 72-year-old DCD donor, so a poor quality donor, which at the time of the retrieval surgeon said, this liver is awful, it has perfused very poorly in situ, it's not usable. He phoned the transplanting surgeon who said, yep, I don't want it. But we were there at the donor hospital already with the machine set up, and so on the phone we just said, why don't we put it on the machine and see what happens? And he said, okay. So we put it on the machine, and to our surprise, it started functioning. So we phoned the transplanting surgeon and said, the liver's functioning well. And he said, okay, we'll come to the Royal Free Hospital and we'll see what happens. And we arrived there about 2 a.m. and the surgeon was in his suit and he said, look, I'm going home now. You can do what you want. But if when I come back in at 8 o'clock in the morning, you've still got a functioning liver, then come back and talk to me. So at 8 o'clock, well, he didn't quite say it like that, but at 8 o'clock when he came back, the liver had been on the machine for 11 hours and 10 minutes. It had 500 mils a minute going through the artery, a litre a minute going through the portal vein. The pH was normal for a liver. It was making bile at 10 mils an hour. It was using glucose nicely, and it appeared healthier than we'd expected. And the surgeon was surprised, but he said, okay, let's give it a shot. So we had a patient who was consented for the trial, had a discussion with him. He was happy to proceed. So we performed the transplant. When the liver came off the machine, it looked awful again, and I got shouted at a bit. And then once it got transplanted, it also didn't look very pretty in situ, but it functioned perfectly from as soon as it was reperfused. And that recipient went on to make a good recovery with that liver still functioning 2 years later. That was maybe the clearest example of a liver that would not have been used that went on to be used. We've had other cases, such as a 55-year-old brain-dead donor who was quite overweight, who again had quite a fatty liver. But in this case, what happened was, at the time of retrieval, it wasn't noted that, if you look over here, you can see a little vessel. That's a left hepatic artery that had been inadvertently divided, not noticed at the time of retrieval. And the significance of that artery is often unknown. Sometimes these can be tied off, sometimes they're important for perfusion of the left side of the liver. So we put this liver on the machine, and it was notable quite early on that the left lobe was very patchy in the way it perfused, although the liver appeared to be functioning nicely. But we got to the transplanting centre in Addenbrooke's, and the surgeons there looked at the liver and decided to try and reconstruct that artery during machine perfusion. So they used the donor iliac artery, which you can see here, the external and internal, to reconstruct it. You can't really see it well, but onto the left hepatic artery. And as the perfusion continued after that reconstruction had been performed, actually the liver went from functioning well to functioning very well, with the flows improving further, the lactate dropped further, and that liver again ultimately went on to be transplanted and functioned well without any problems that could have been related to impaired perfusion of one lobe. And then the final case I'm going to present, this was a liver from a 51-year-old DCD donor, so a poor quality donor, who had a very large fatty liver that had been declined for transplant by all centres in the UK. So this was then offered up nationally for research, and the group in Birmingham had a research study going on where they could put these livers on the machine. So we travelled up there with the machine and put this liver on, and this was a fatty liver that had been on ice for 8 hours by the time we got to it. And this is where we went on the machine, and it perfused nice and homogeneously. After 1 minute, as you'd expect, it was very acidotic, with only 200 mils a minute through the artery, and looked not very good. By 1 hour, the arterial flows had improved a bit. The pH had come up of its own accord, but it still wasn't a great liver. By 2 hours, the flows were still all right, the pH was improving further, the liver had started to produce bile at 6 mils an hour and was starting to look better. And then by 4.5 hours, the flows were better still, the pH was better still, bile in production had continued to improve, and it was now using glucose, so the glucose had dropped from 20 to 11 millimoles. So the team went on to transplant that liver, and again that liver functioned well after transplantation and is still functioning well 2 years later. So in summary, from the clinical studies we've done, we've shown that normothermic perfusion is associated with less early graft injury after transplantation. And this is despite higher organ utilization in the normothermic groups and substantially longer preservation times. And we've also shown that it appears to be the case that we can use normothermic perfusion to assess organ quality to help guide clinical decision making. And these findings have gone on to be published recently in Nature. I'm now going to hand over to my colleague, Carlo.
Thank you very much, David. So as we've already heard, normothermic machine perfusion has been implemented successfully in the clinical context, but one key thing that I was looking to investigate was whether you could recondition organs and improve organs, so organs that maybe weren't functioning, could you actually further enhance them? And fatty livers, as we've heard, do particularly poorly when transplanted, so these are a very good type of organ to try and recondition and enhance. So why do fatty livers do so badly? A fatty liver, basically when it's transplanted, and if there's more than 30% of large fat droplets, as you can see the white circles here within the liver, that's been shown to decrease post-transplant survival by up to 70%. And this is largely attributable to ischemia reperfusion injury. So these livers have a much more exuberant inflammatory response, increased neutrophil infiltration, reduced ATP production, mitochondrial dysfunction, and impaired blood flow, which lead to these poor outcomes. And as a result, a large number of these livers are discarded. Around 1,000 fatty livers in the States are discarded each year. That's in the context of about 6,000 transplants a year. In the UK, half of all discarded livers are due to steatosis. So it's a big problem. The problem's made worse by fat donors, which are increasing. So obesity is a risk factor for fatty liver disease, and now a quarter of donors in the UK are clinically obese. So in the context of not enough organs available for transplantation, we need to try and optimise the ones that are available to us. So as David's already presented us the clinical trial, we looked at a subset of fatty livers that were transplanted and matched them to lean livers that were all normothermically perfused. And what you can see here is fatty livers, unsurprisingly, mobilise more fat into the circuit during preservation, and also have more fatty acid oxidation as measured by 3-hydroxybutyrate. But if we looked at the degree of steatosis over the preservation, unlike what had been shown in animal models, actually the total amount of fat before preservation, after preservation, and after reperfusion remained largely unchanged. And if you compare the post-transplant outcomes in these livers from a steatotic compared to a lean liver, actually the steatotic livers had more preservation injury in terms of peak serum AST than their lean counterparts. So the question is, can we get these livers to perform as well as these livers by enhancing them during preservation? In order to do this, a brief understanding of liver fat metabolism was important, for me anyway. So the liver gets fat from various sources, from diet, from mobilization of subcutaneous fat or visceral fat as non-esterified fatty acids. And these all contribute to the fatty acid pool within the liver, as well as de novo lipogenesis. Within the liver, they can either be stored or follow two pathways, either oxidation, so that's via beta oxidation in the mitochondria, or very low density lipoprotein secretion as esterification, which then gets restored again peripherally. But actually in the ex situ circuit, there's no diet, there's no subcutaneous fat, and there's no visceral fat. So the only source of fat within the liver is this de novo lipogenesis pathway. So this is where the liver makes fat from non-lipid precursors, mostly glucose, and the end product is palmitic acid or palmitate. And this process is stimulated by insulin. So basically I took all livers that were discarded because of steatosis. So all 7 UK transplant centres said, no, it's too fatty, we don't want to transplant it. They came to Oxford, were cannulated and perfused on the circuit. Labelled water was added, and this allows us to quantify newly synthesized fatty acids via gas chromatography and mass spectroscopy, and livers were perfused for 48 hours with frequent blood gas sampling, perfusate analysis, and 12-hourly core biopsies. So a total of 21 livers were taken during this period. 3 were excluded as they didn't demonstrate any evidence of function. So this allowed 18 48-hour perfusions. 6 livers were perfused on the machine by itself. 6 livers were then perfused on the machine with the addition of this LDL apheresis filter. So these are filters that are used in patients with very high cholesterol that's refractory to medical treatment, and it essentially mechanically filters out lipoproteins. And in the final group, as well as the filter, we added some drugs. So forskolin increases esterification and VLDL secretion. L-carnitine shifts fatty acids to the mitochondria for beta oxidation. And then we tried to reduce de novo lipogenesis by reducing the amount of insulin and glucose that were delivered to the liver. This is my wife, who I think I was able to convince that her coming in at 3 o'clock on a Saturday morning counted as spending quality time together, and it probably just about saved their relationship. So if we look at the demographics of the livers, there were 6 in each group, and actually they were quite similar. There were 4 DBDs and 2 DCDs within each group, and yeah, they were otherwise well matched. The cold ischemia times were up in the region of around 12 hours. Often these livers did a bit of a UK tour before they finally made it to Oxford. So they actually had quite a lot of injury already sustained before they arrived. If we look at the basic function in terms of pH, normalization, lactate clearance, and glucose metabolism, actually all the livers performed in a similar way. And this is important in the context of comparing metabolic function, that their baseline function was quite similar. Unsurprisingly, the glucose of the third intervention group was lower, which is what we targeted. Looking at the ALT transaminase in the perfusate itself, actually all increases, but it only increased significantly in group 1 where there were no interventions. The baseline ALT level is a reflection on the amount of injury that's already been sustained in the liver, and any ongoing enzyme release is probably reflective of ongoing injury. So that seems to have been attenuated in the second 2 groups compared to the first. Hepatic arterial flow was also significantly higher in our intervention groups, potentially here reversing the impaired sinusoidal blood flow that is known to occur in steatotic livers. And in NMP alone, indeed, there was a reduction in arterial flow during preservation. Portal flow remained unchanged in the groups. By adding this filter, we were successful in mechanically removing triglyceride from the circuit, and this, in theory, could reduce the amount of lipotoxicity, which has also been shown to impair liver function. The same was true for cholesterol, and we also saw a shift in fatty acid partitioning when L-carnitine was added towards the oxidation pathway, so those fatty acids, rather than being stored, are being oxidized. So how does this actually result in the amount of fat within the liver? And by measuring biochemically, by homogenizing the liver tissue and measuring the amount of triglyceride, there was a slight increase in the liver's NMP alone group, but actually a 45% reduction in our treatment group. And this change was significant compared to the slight increase. Here you can see, I'm not sure if you can see it very well, but lots of large lipid droplets at time 0, and they've more or less either become very, very small or disappeared by 48 hours. And this was actually associated with a significant reduction, but 48 hours, in the amount of DNL fatty acids, namely palmitate. So this is by reducing glucose and insulin, we actually reduced de novo lipogenesis, and that probably accounts for the reduction of fat within the liver. So to conclude, this demonstrates that we can successfully manipulate hepatic lipid metabolism in the ex situ setting. The addition of the filter improves function of the liver, but didn't change the amount of fat within the liver. However, by adding L-carnitine, altering insulin and glucose, function improved, fatty acid oxidation increased, and there was a reduction in de novo lipogenesis. So this shows that actually moving on from using the device as it is, there's potential to exploit things even further to try and transplant even more livers with good outcomes. I'll now move back to Prof, who's going to round us up.
Thank you very much, Carlo. So really just to finish on this theme of using normothermic perfusion as a platform to treat a liver rather than simply a means of preserve the liver, this is clearly an opportunity, and it's an opportunity which has been more or less non-exploited so far. It's very exciting. We could give drugs. We've just heard Carlo's excellent work looking at approaches to reduce the fat content of livers. There are other drugs which we can use which will mitigate the effects of the inflammatory effects of ischemia reperfusion. There is some very nice work just beginning to emerge using nanoparticle technology to deliver drugs to endothelium. There is a lot of interest in the use of cell therapy, mesenchymal stem cells, which have natural anti-inflammatory properties, regulatory T cells, which reduce the immunogenicity of an organ, and gene therapy. There is evidence experimentally of giving, for example, IL-10 as a gene therapy to reduce the inflammation in a graft. There's experience of giving CTLA-4 Ig, which is one of the immunomodulators, to make the organ less likely to reject. These are just some examples. None of these have been done in clinical practice yet. These are all experimental studies. They're all waiting to be done, and there are many, many more. That's just a few, as it were, picked out of the literature. This is an illustration of why normothermic perfusion might enable this. It doesn't matter which gene was being used. As it happens, it was an oligonucleotide called miraversin, which is a strategy which might prevent hepatitis C reinfection of livers. That doesn't matter. What's important is in the graph, which shows just how much more effectively the gene is delivered in a normothermic, a warm perfusion environment compared to cold storage. So is this going to change the future? Is it going to change how we look at organ preservation? Is organ preservation going to become a much more active process than it currently is? One might envisage a time in the future where organ donation, of course, still happens where it happens, in hospitals all over the country, all over the world. And if the organs are completely straightforward, there's no reason perhaps why they shouldn't be simply transferred to transplant hospitals and transplanted pretty much as they are now. But what about delivering the high-risk organs to specialist reconditioning centres where the organs are placed on perfusion devices, they are assessed, and depending on that assessment, they may be treated with interventions as yet unspecified and then tested again. And if they pass the criteria, they then get transferred for transplantation, and if they don't, they're discarded or more likely used for research. Well, that all sounds like quite an exciting possibility for the future. Of course, the future is often a lot closer than we think. This is a small organisation, it's a small company called Lung Bioengineering based in Maryland, Silver Springs, Maryland. This building has been built with the express and sole purpose of reconditioning lungs for transplantation. So lungs which fail to meet the criteria for lung transplantation are flown into this institution, they're put on a machine, they're treated. If the gas exchange and other parameters improve, they're taken off the machine and sent out somewhere to be transplanted. So this is perhaps a vision of the future, and is this perhaps a new science? Is this a new clinical science? This is going to evolve in perhaps the same way that tissue typing did in the 1960s and 1970s. It remains to be seen, but it would seem to me a very likely possibility. And remember, what we're dealing with at the moment is essentially first-generation technology. We all know what happens to technology. Thank you very much indeed for your attention. I'm very happy to take any questions, as are the others.